The best of RSNA is coming to you in these two exciting new Spotlight courses. Explore head to toe emergency imaging in the virtual Spotlight course, Best of RSNA Insights, Innovations, and Interactive Learning in Emergency Radiology, taking place April 3rd and 10th. Or join top presenters from RSNA in Istanbul, Turkey for the in person Spotlight course, Expert Insights on Emergency and Abdominopelvic Imaging, on June 28th and 29th. Learn more about both courses and register at rsna.org/spotlight.
Hi, everyone. Welcome back to another RSNA Radiographics podcast. My name is Dr. Lily Wang. I'm your host for the day. I'm a neuroradiologist from the University of Cincinnati. Today, I have a very special guest, Dr. Aakanksha Sriwastwa. She's a radiologist trained in nuclear medicine and currently pursuing neuroradiology fellowship at the University of Cincinnati. Today, we are going to talk about the review article we co-authored with colleagues from the Departments of Radiology at the University of Cincinnati Medical Center and Cincinnati Children's Medical Hospital Medical Center. The topic is nuclear medicine imaging in epilepsy. Aakanksha is our first author. Thank you so much for joining me on the podcast today.
Sure, thank you for having me.
This article has great examples across multiple etiologies of epilepsy affecting both adult and pediatric population. It explains the pivotal role of nuclear medicine in epilepsy. Let's dive in, shall we?
Yes, of course.
First, how common is epilepsy?
Well, not uncommon at all. It affects 1 to 2% of the global population, approximately 2.5 million people in the United States, and 70 million people worldwide have epilepsy. It is a disorder defined by 2 or more unprovoked seizures. So not only it is more common than we expect, but it can also result in lifelong morbidity for the patient. So it is important to appropriately diagnose and treat epilepsy.
So our article focuses on medically refractory focal epilepsy. How common are these?
So approximately 60% of epilepsy are focal epilepsy, meaning that the seizures originate from a specific area of the brain. When incapacitating focal seizures keep occurring, even after trials with 2 anti-epileptic medications, alone or in combination, this disorder is termed medically refractory focal epilepsy, or we call it MRFE. Now, unfortunately, despite advancements in anti-epileptic drugs, up to 30 to 40% of patients develop MRFE, which is significantly impacting their quality of life.
So what is the outcome of these patients with MRFE?
So the good news here is that a carefully planned resective surgery can lead to seizure freedom in approximately 2/3 of the patients with MRFE. However, a very diligent and structured multidisciplinary approach is required for the optimal workup of these patients. Nuclear medicine and neuroradiology are both very important stakeholders in the diagnostic workup for these patients.
Yeah, in our hospital's multidisciplinary epilepsy surgery conference, we always have radiologists and nuclear medicine radiologists in attendance. Of course, in addition to the well, I can never say that word, epilepsy neurologists, neurosurgeons, nurses, clinical psychologists, and nurses. So we start with the history and reviewing the imaging of the patients. Why don't you tell our listeners how we work up these patients?
The usual for imaging in epilepsy is a good quality epilepsy protocol MRI brain, which is the mandatory first step. Now, a significant proportion of focal epilepsy cases originate in the temporal lobe and are referred to as temporal lobe epilepsy. Then there is a second group, which is based on the anatomic location of the epileptogenic focus, and it's called the extratemporal epilepsy because it originates outside the temporal lobe, that is from the other lobes of the brain. Both TLE and ETLE have lesions that are detectable on MRI. However, there is a third group, which is called the non-lesional epilepsy, that comprises approximately 1/3 of focal epilepsy patients. No lesion is detectable on anatomic imaging in these cases. Functional imaging plays a crucial role in the imaging workup of these cases. Moreover, even in cases of temporal and extratemporal epilepsy, when MRI and functional imaging show concordant findings, the confidence level for the lesion as epileptogenic focus increases.
What happens when a patient with MRFE is referred to the epileptology clinic?
The first or the initial evaluation includes assessment of seizure semiology, continuous video scalp EEG, neuropsychological assessment to establish a baseline, and a high-resolution MR epilepsy protocol imaging. If the results from these four modalities are discordant or inconclusive, which they frequently can be, further non-invasive evaluation is performed. This includes one or both modalities of functional imaging, that is 18F FDG PET and ICTL and baseline SPECT. It can also include MEG, that is magnetoencephalography, PET MRI, EEG fMRI, or a combination of these modalities to improve the diagnostic confidence for surgical planning. Concordance among the multiple diagnostic assessments has been shown to facilitate better and safer post-surgical outcomes.
Yeah, it's definitely great when the results are concordant. It makes it much easier to manage the patient.
I totally agree. And surgery is only considered after we have ascertained the location of eloquent cortex and important white matter tracts in relation to the epileptogenic focus. In order to determine the language dominance and the relationship between a lesion and the white matter tracts, functional MRI and DTI or diffusion tensor imaging can be performed. If the epileptogenic focus, as determined by concordance on multiple diagnostic modalities, is in the non-eloquent cortex, the patient is considered a surgical candidate for epileptogenic focus resection. However, on the other hand, if the lesion is found to be in eloquent cortex, there is possibility of considerable neurological deficit after surgical resection. The patients are instead considered for MRI-guided laser therapy, neuromodulation, or stimulation techniques using vagal nerve stimulation or responsive neurostimulation or deep brain stimulation in such conditions.
What happens if the lesions are discordant based on the non-invasive diagnostic tests?
Well, in the case of discordant or inconclusive tests, a phase 2 evaluation, which is an invasive evaluation, can be performed. This evaluation is invasive and involves subdural grid electrodes or depth electrode placement to detect the focus of origin of the seizures. The aim is to accurately localize the epileptogenic zone to determine its amenability for surgical resection.
Thank you for summarizing the workup and pre-surgical planning of patients with MRFE. Returning to our main topic, nuclear medicine's role in the workup of epilepsy patients. What are the various functional imaging studies we can employ in localizing the epileptogenic zone?
There are two. PET and SPECT are the two functional imaging modalities commonly used in clinical practice for epileptogenic zone detection. Now, 18-fluorine FDG PET, as we know, assesses the differential uptake of radioactive glucose in various body parts and here in various areas of brain to analyze their metabolic status. Epileptogenic foci are characteristically hypometabolic in the interictal phase, allowing the localization in a background of typically high cortical uptake. This hypometabolism is due to neuronal loss, reduced synaptic density, or diastasis, and it may be associated with the duration, frequency, and severity of the seizures.
And what about SPECT? How does that work?
So, SPECT imaging uses tissue perfusion, contrary to tissue metabolism by PET, as an indicator of epileptogenic zone. Now, synchronized neuronal discharge activity during seizures increases cerebral blood flow in and around the epileptogenic zone by up to 300%. And an ictal phase SPECT imaging relies on this relative hyperperfusion. Now, interictal SPECT imaging typically reveals relative hypoperfusion of the epileptogenic zone compared to the background brain tissue. Two agents, that is technetium 99 ECD and technetium 99 HMPAO, or the hexamethylpropylene amine oxime, are used for SPECT imaging.
What is the difference between these two agents?
Yeah, so they have physiological differences as far as uptake time and excretion time are concerned, and also some differences in their background uptake. Although both these radiotracers are available, most of the institutes generally stick to one or the other for their regular clinical use.
Is there any preparation or special setup required for these imaging?
Yeah, I'm glad you asked this because this is very important, especially in cases of ictal SPECT imaging. Now, ictal SPECT relies on radiotracer uptake during active seizures. This process is logistically demanding at multiple levels. The patient needs to be admitted to an epilepsy monitoring unit or EMU, and anti-epileptic medications are withheld. Continuous scalp EEG monitoring is performed. Once the seizure onset is identified, the radiotracer is injected manually or with the use of an auto-injector, preferably within 20 seconds of seizure onset. This requires a lot of coordination and promptness as this step forms the basis of successful ictal phase spectrometry.
Yeah, I always feel like the techs have to be trained to sprint to give the tracer at the speed of lightning.
True. On the other hand, interictal SPECT and theta imaging are relatively less technically demanding. It is important to ensure a seizure-free status for at least 24 to 48 hours before performing these scans. For FDG PET imaging, the patient needs to be NPO for 4 to 6 hours with blood glucose level below 200 milligrams per DL, similar to the preparation for other indications of PET imaging.
How accurate are these imaging studies in seizure focused localization?
Yeah, that's important, right? So, in the setting of temporal lobe epilepsy, FDG PET has a reported sensitivity of 85 to 90%, so pretty good. The size of the epileptogenic zone may, however, be overestimated by FDG PET, and it correlates with the recent frequency and severity of seizure. That is how well the seizures have been controlled. Interictal SPECT alone has low sensitivity of around 50% or less. Ictal SPECT, on the other hand, can enable accurate localization of the epileptogenic zone in 70 to 90% of unilateral temporal lobe epilepsy cases, and the sensitivity increases to 93% with the use of SysCom.
That's super helpful. Can you explain what is SysCom for our listeners?
Sure. SysCom is a fun acronym, right? It stands for Subtraction Ictal SPECT Co-registered to MRI. In addition to qualitative visual assessment of ictal and interictal SPECTs separately, SysCom allows for semi-quantitative analysis by subtracting interictal and ictal images and registering the result with MRI. It takes advantage of the relatively greater ictal radiotracer uptake versus uptake in the background brain tissue and relatively less interictal radiotracer uptake in the epileptogenic zone. So, this interesting technological advancement in post processing and image display increases the sensitivity of epileptogenic zone detection in temporal lobe epilepsy from close to 80% by ictal SPECT to approximately 93%.
That's pretty sensitive. How helpful are these modalities in cases with extratemporal or non lesional epilepsy?
Sure. So for extratemporal epilepsy, the overall sensitivity of radioisotope imaging is lower, somewhere around 50 to 60%, when compared to the sensitivity for detection of temporal lobe epilepsy. Ictal SPECT can determine an extratemporal epileptogenic zone with 50 to 75% sensitivity, while FTG PET has a sensitivity ranging from 45 to 92%. Ictal SPECT has high sensitivity, that is more than 80%, for detection of epileptogenic zone in non-lesional epilepsy. PET, on the other hand, has variable sensitivity for epileptogenic zone in non-lesional epilepsy, ranging between 46 to 75%. So, in our article, we have discussed and shown multiple case examples of patients with focal epilepsy where PET and SPECT imaging were helpful in detecting lesions in non lesional epilepsy cases and showing concordance with the lesions detected on cases with positive MRI findings, thereby increasing diagnostic and pre surgical confidence. We have also discussed postoperative surgical pathology and long term follow up of many of these patients.
Very interesting. Yeah, we definitely encourage our audience to visit the article. There are a wide variety of peds and adult epilepsy cases with discussion. Akansha, can you please briefly enumerate the epilepsy causing disorders that we discussed in the article?
I would love to. So we steer our discussion from the more common to the lesser seen etiologies of focal epilepsy. We start by discussing mesial temporal sclerosis that accounts for about two-thirds or more of temporal epilepsy. We then discuss focal cortical dysplasia, meningoencephaloceles, AVMs, and epilepsy-causing tumor, including DNETs, gangliogliomas, and pleomorphic xanthostrocytomas. Then we step into epilepsy syndromes, including tuberous sclerosis, Sturge-Weber syndrome, hemimegalencephaly, and Rasmussen's encephalitis. We also discuss cases of congenital neuronal migration and cortical organizational disorders, for instance, pachygyria polymicrogyria complex.
Yeah, we definitely used up the radiographics image limiter. We usually think that in the case of epilepsy syndrome, we usually see what we need to see on the MRI brain. So, what is the role of nuclear medicine in these cases?
Great question, and a very important one indeed. So I agree. MRI helps us to see a lot of things that are going wrong with the brain in a case of epilepsy syndrome. For example, tuberous sclerosis. In tuberous sclerosis, we can see multiple cortical tubers. We can assess their location, size, temporal evolution, and other characteristics. But how do we know which tuber or tubers are epileptogenic? Frequently, only one or few of these multiple tubers are epileptogenic, and a careful resection of these tubers can lead to seizure freedom. PET and SPECT imaging help us delineate the tubers that are discharging epileptogenic spikes by the extent of locoregional hypermetabolism or hyperperfusion, respectively. In addition to this information, functional imaging also helps to ascertain the functional integrity of other areas of the brain and can detect any hidden and epileptogenic lesions in otherwise healthy appearing brain.
Okay, well, our listeners are armed with the knowledge that and ready to read these nuclear medicine studies. Are there any pitfalls that they should be aware of?
Yeah, so everything good comes with some shortcomings, right? Functional imaging modalities have good sensitivity for detecting functionally altered regions of brain. However, their spatial resolution is suboptimal, and we have to rely on structural imaging like CT or MRI for this component of image interpretation. This is true for any functional imaging modality for any body part imaged. Additionally, the subjectivity of image interpretation can be decreased by the use of post processing and automated softwares that also increase the sensitivity. However, this occurs at the expense of risk of introducing artifacts. Moreover, because of the logistical and technical challenges involved with ictal SPECT imaging, these can fail in about 20% of the cases.
Kanshas, thank you so much for your time. That was a really great discussion. I thoroughly enjoyed our talk to you about nuclear medicine and imaging in epilepsy. Thank you everyone for your attention. Please check out the article on the radiographics website for the beautiful images. See you next time at the next episode of the podcast. Bye.
Bye bye. Thank you.